Thank you, everybody. I appreciate coming and talking with you all. It's always fun for me to talk with different people, and you're a different group of folks for me, the surveyors. So I'm a service provider, so it's exciting for me to talk to you. So I wanted just to quickly tell you a little bit about myself and my passion in this area. So I started at Calgary Scope Society 30 years ago at the age of 25, and it has been a really interesting journey. For those of you who probably have gone similar journeys, Calgary Scope Society believed that all people belong in the community and that we didn't believe in any restrictive practices at all. And that's how we first started at Scope, and we helped a very, very complex group of individuals come into community. And so we've been on a really steep learning curve for many, many, many years. And some of that learning, we were seeing people that we were serving getting entangled in the system, into the justice system, into hospital, getting charged because there'd be assaults with staff. And very quickly we learned we actually were going to institutionalize the very people we were trying to serve in the community. So we really had to revisit kind of our thinking about what do we need to do to help people be in the community. I was asked to think about a different way to rate people, rate services. So as you know, our sector went through the CIS assessment where we were looking at how do we decide what services people need based on their assessment and a number assigned based on their needs. And this proved pretty problematic. As you know, lots of people were rating really low, that in fact had very, very complex needs, and other people were rating very high that had very low needs. So it was a real struggle, and there was definitely some pieces of subjectivity with the interviewers there involved in the CIS. So we were trying to look at a different way of looking at how do we make sure that people have what they need for services. Lots of people are familiar. We were doing some work on the fatality inquiry and did a panel at the ACDS conference. And for those of you that aren't familiar with that situation, it was a situation where a caregiver was placed with an extremely complex needs individual without any other services. And in fact, that individual with complex needs had killed that lady during the night. That not only our clients are safe in services, but that our caregivers and our community are also safe. So this is new, and I believe it's still a work in progress. I don't feel we've accommodated the medically fragile well in here yet. I think there's lots of additions to come, and I think you folks will help us do that. But we tried to look at a way to look at service needs for people as opposed to rating people. If you can imagine, just even across this room, looking at each of you, could you imagine us trying to rate your needs and the complexities of each of your lives in this room? It's almost an impossible endeavor. But what we can do is look at what services do people need? And so that was a shift for us that looked a little bit, made some sense. So when we're talking about, so we've divided it into just 3 tiers, so a fairly simple process of looking at services for people. So our tier 1 looks at individuals who have developmental disability. This is our population that we've been mandated to serve for many years. I think lots of our standards are actually built around this group of people. And so these standards make really good sense. And so I think this tier 1 is something we're all very, very accustomed to. People with developmental disabilities, there are no existing complex needs, mental health, medical, or behavioral challenges. So we're really talking about people with developmental disabilities as a whole. When we look at types of service models, there's all kinds of types of supports that people who are what we consider tier 1 live in. So we've got staff models, we've got shared supports, supportive roommates, supportive neighbors, hourly supports, and family managed care, and also independent living. So as you can see, there's a really broad number of ways that we serve people, and I'm sure even amongst you all, you've come across other ways that I haven't listed here. These are just some of the ways we see people being served. So talking about, this is where we've started to do the work. What are the requirements for organizations serving people in Tier 1? And we've got a group that is able to hold current certification through ACDS. They're eligible to receive PDD funding, and they train to the standards and CET requirements. So all of you in the room would know those standards better than I do. Your basic kind of accreditation process. That's what we're looking at for our Tier 1 folks. We're starting to think a little bit more about what else do people need to work with this population. And I think there's lots and lots of work to do here as a community around what are the ways we can better serve people. But a couple are really jumping out, I think, as we see our workforce changing. Talking about the history, I think Foundations is a really, really important course for people to take when serving folks. I think it's very important to understand the history of people with developmental disabilities and also marginalized people in general, right? We need to learn about those movements. How do we empower people? How do we be part of the disabled community to help them to just create quality of life in the community? So we're talking about trauma-informed care. And it's interesting to see trauma-informed care here in Level 1, and I'm curious what people think about that. But as we learn more and more about trauma, we are recognizing that in fact most people have experienced some trauma in their life that may or may not lead to some challenges later in life. And so just thinking around the room, most of us have experienced divorce, death of people who are close to us. There could be trauma in our younger years in school. But we are actually recognizing that many people, in fact most people, have experienced some level of trauma. So then you look at the disabled population and think what it's like to be a disabled person going to school, right? Being bullied by others, the experience of being an adolescent and struggling with dating, being a young adult and coming to recognitions like I may not be able to have children or get married or go to university like my siblings. We also look at the history of people with disabilities, and lots of us know people we serve some folks have been bounced around from service to service to service to service. Not only that, a lot of people we serve have been institutionalized because they've been very challenging. And so I think it's just a critical component that we all become knowledgeable about trauma-informed care. Generally speaking, trauma is often disclosed at a frontline level. And so lots of people say, well, why do our frontline staff need to be informed on trauma? Well, generally that disclosure often happens with that frontline worker. And so we want to teach the people that we're serving, how do you handle that? What do you do with that? How do you connect people to what they need? And how do you ground them in the present so that the trauma cycle can be maintained for people properly? So hoping that makes sense to folks. Mentoring and capacity building. So our last column, we're trying to look at knowledge transfer strategies. So these are just some ideas, and again, this is an area I think all of us will work on and develop further. But we're talking about our explicit knowledge, so tangible things we have, the enhanced foundation, trauma-informed care, and training specific to disabilities. Now, in this area, I think one of the most challenging things is how many pieces we need to train on. So even within Tier 1, and one thing I want everybody to understand is I do believe all of our work is complex needs. Even folks under Tier 1 can be extremely complex, right? And people are coming with multiple disability issues. So people need to be knowledgeable about developmental disability and, say, epilepsy and Down syndrome. And I'm sure amongst the room there's probably 50 different things that some of our organizations are trying to train on, just under Tier 1. And so as surveyors, that's a very challenging thing, because we can't put just a blanket standard in place on all the things we have to train for every single person in your services. But what we do need to do is look at, do organizations have resources to make sure that we are training customized services for people with developmental disabilities, so all the people in their circle are really in the know about what they need and what types of services they are requiring. Tacit knowledge, we're talking about what are the other things that we can do to enhance our learning as a community. We've thought about storytelling and expert speakers, clients, frontline workers, think tanks about oppression and the disability movement and social justice. And looking at a community of practice for frontline, that's something we're seeing maybe potentially ADWA could do, so that we can start really mentoring our body of frontline workers out there in this area. So that's really what we're thinking about under Tier 1. So I think that one is fairly straightforward for most folks. And then we're going to look at our Tier 2 folks. And so I believe that we are serving very, very high numbers of people under Tier 2. So Tier 2 really talks about, we're looking at individuals, again, that qualify for PDD funding. So we're looking at a developmental disability. But individuals may have an accompanying mental health diagnosis, medical issues, or behavioral aggression, behavioral issues, and self-harm behavior. So again, so now we're doing a shift. You can see the shift in the service needs. How do we look at supporting these individuals properly? This group is often labeled as our complex needs group. And so we also, within this group, experience some folks who pose risk to self and others. So now we're starting to get into our complex needs services. Risk may necessitate the use of restrictive practices, including physical intervention. And so I'll just want to tell you a quick little story about what happens when you don't do some of these things, because we've experienced that at Scope. We've been on a continual process of experiential learning. And we used to serve a young man who used to run a lot. And he was a young man of 18 years old. And he had been running when we started serving him for 4 years at the time already, running every day. And we didn't really understand what the running was about. He used to run to a park, and he used to run to his parents' home. And so, you know, our knowledge at the time said, we don't believe in restrictive practices, and this client has choice. And so we're going to facilitate the running. It sounds ludicrous when I think about this story now, but it's what our knowledge base at the time. So this individual was actually running to his rape site. And so he had been traumatized as a young man in a park by another gentleman. And so he had post-traumatic stress disorder. And it wasn't diagnosed at that time. And we didn't have a clue what was happening with this man. All we knew is he wanted to run every day, and our belief system at the time said we shouldn't stop him. So what did we do? We facilitated his running. We taught him how to run safely, whether there's such a thing or not. And there really isn't for someone like this. So this individual, we taught him the bus routes, and we packed a backpack for him, because he would be on the road about 16 hours a day. No coat, no shoes, and he had miles and miles to go to reach his destination. He usually crossed the whole city, including some really dangerous train bridges on the way. So we spent a lot of time searching for this man and returning him home. One night, this young man ran, and what we didn't understand is he triggered during the run. So he had post-traumatic stress disorder, and he triggered to his abuse every time he ran. And he ran, and he would start running, and he wasn't paying attention to traffic lights. He was no longer doing all those functional skills we'd worked so hard to teach him to be safe. That all went out the window when he was triggered by his trauma. He ran diagonally through an intersection one night and was hit by a speeding car. He was in a coma for 3 months following that accident, and there was a decision to pull him off life support after 3 months, and he lived. And he is still in our services today. But the learning for us in that situation was a real starting to shift our processes as an organization, because we now understand that that wasn't appropriate for that young man to continue to be living his cycle of abuse, and we were facilitating it. So that's just an example of why we really want people to understand the mental health and the complexities that start coming in at Tier 2. And I do believe this is a majority of folks we serve. Lots and lots of folks we serve fall under Tier 2. So we've got, again, some similar types of residential models. We have staffed models, shared support, hourly support, independent living, family managed care. I think one thing that's worth noting is we do see within this group more difficulty living in supported roommate models. It's called all kinds of things in our sector. Tenant support, roommate, paid caregivers that you live with is what we're talking about. What we experienced at Scope was, it was like people were just guests wherever they went in the supported roommate model. And so dealing with a complex group, what we found was the folks we were serving just kept getting kicked out. So they're moving and moving and moving and moving, trying to create home, but the minute they would have a behavioral issue, generally they would be evicted, right? If they assaulted their caregiver or broke the window of the house, or so it's worth noting at this time, this is where we start seeing challenges in service, right? How do we serve this group better? And I think the learning is to make sure that people are placed in an environment that is safe and a good fit, and that is going to work in the long term for people. We also see here the beginning of environmental safeguards. Now, you might see this under tier 1 as well. Often we see medications need to be secured for people, right? Or sharp things like butcher knives and things like that. In lots of services, you will see those items secured, right, for safety. And so you will start seeing more restrictives with this particular group. And lots of individuals within this group will share with you things that are unsafe. You may have individuals within this group who engage in cutting, right? Self-harm behavior. And there may be some quite unique systems that you need to put in place around that. Around the organization, again, we're looking at PDD eligible groups. We're looking at adequate insurance. This is where things like insurance start coming into play a little bit differently, right? Have you got proper insurance? Are your staff well supported if they get injured at work? This is the one change. So now we're believing and thinking that at this point people would be required to have the complex needs certification. And so that's one change. So at tier 2, we're talking about individuals and services, our services having complex needs designation through ACDS. So that's a shift. And that does affect lots and lots of our organizations in the community. And there was a couple tone things that Clova had talked to me about, and I believe that Clova's bang on with this around how do we communicate with organizations about what they do? Sometimes we have a different language than you folks do as surveyors. And I can think back as an experience for our own agency when we didn't do well with CET. And there was a number of language barriers that we had found in our own service. We weren't calling things what you're calling them. And that was very, very confusing for all of us when it came time to share with you our stories about what we do. And I think Clovis kind of shared with me, it's really, we're looking for conversation with organizations about what do you really do? Because complex needs services to me are a gray area. And I'm sure you can see that more clearly than I can, because you're out there at all these organizations seeing all the different things people are trying to help serve, right? What kinds of people we're trying to serve, and how do we make that work? And so I think the message that I was given is really we're more after the essence. Tell us about the essence of the standard and indicators in your service. Let us understand. Teach us what you know. How do you do business and practice? And so it's really about, I think, the vision of coming in as a partner. We are partners with you, and we can work together to get to a better place. And I think that's the tone. And I think for organizations for years, we prepare hard for the surveys. And sometimes we worry, that there's an authoritative body coming and looking at what we do. And the message that I'm understanding from ACDS is that we want to shift that a little bit more to the partnership and the learning together. Where are you now? What are the challenges you're facing as an organization? And how do we help you to get to where you need to be serving people with complex needs? So that's our first shift. We're looking at the organization supports the level of intervention required to address the safety concerns of the client, staff, and community. So a good example of this is we want to make sure that we don't have someone working in an unsafe situation, for example, by themselves. So say you've got a man who's 6'2" and very aggressive. We want to make sure, how are you making sure that that staff member is safe in that environment? What safeguards are in place to make sure that things like our fatality inquiry don't ever happen again? In our sector, we're learning about this and getting better at this, but there's lots and lots of work to do in this area. Adequate infrastructures in place for responsive and appropriate on-call services. So now we're starting to look at things like, what are the after-hours supports for staff when no one's around to help? Is there someone they can call when they're in running into difficulty supporting the person they're working with? If there's safety issues, if there's mental health issues, what's their backup plan? So here we're starting to think again, how do we make sure people are safe out there? Because lots of our employees work by themselves out there, right? And they are working with people with complex needs. Again, the mentoring and capacity building, we're talking about things like mental health training. And this is a challenge for our sector. Lots of people in our sector are trained in different disciplines and are not experts on mental health. However, serving complex needs individuals, you actually need to become experts on mental health in pockets. And so here we're talking about some examples of training would be mental health first aid, which is super training for introductory level training for frontline staff. We also need the advanced mental health learning opportunities, and I think for all of us as a sector. We serve individuals who are predatory sex offenders. We serve high numbers of people with personality disorders. We serve high number of people with post-traumatic stress disorder. And so that requires some very specialized services and also a level of understanding so that we can be effective in our services. I can give you a couple funny examples in here that would demonstrate why it's important to understand mental health. And so, folks with personality disorders, certainly a group that I'm totally fascinated with and have done many, many years of work with. We've learned a lot about this group. And in fact, there's some very, very simple things that we can teach our staff about supporting this group. So this group is generally referred to a very manipulative group. It's horrible language, but that's how this group is often referred to out there in our sector. And in fact, many hospitals will decline admitting people with borderline personality disorder. They are a group that live in chronic chaos for the most part. They have periods of stability, but they will always be a challenge to regulate and keep safe. And so, just thinking about this group, we learn a number of things. So they're referred to often as a manipulative group. And that doesn't give you many tools as a staff person. If you said, oh, this person you're working with, they're really manipulative. Imagine the mindset that gives you as that frontline worker. It kind of starts you off on the wrong track. When really, what we need to understand about people with personality disorders is that they're suffering. The behaviors are caused because they're suffering. And so that's a very different response when you're thinking about somebody who is suffering as opposed to someone who's trying to manipulate you. 20% of people with borderline personality disorder will complete suicide. That's a really high number of individuals. And we serve lots of these guys in our services. And lots of these folks are not diagnosed yet. Often the group that's failing at service after service after service, in hospital, in jail, lots of those groups generally end to fall under the personality disorders cluster. And so it's really helpful to services to have knowledge. And I think what will become out of this tier, I'm hoping, and I'm looking at Clova, but we really need some resources to train our sector on some of these things. And our province, I think, is quite aware of that. But we need to do better at providing the resources to all of us to serve this population better. Understanding behavioral learning principles is critical. If we're looking at helping people to heal and grow, it's not different than the non-disabled community when we're trying to change something. If I'm going to go on a diet, I might develop, I'm going to lose 10 pounds and then I'm going to get a new dress. There's all kinds of things all of us do to reinforce our own behavior and support behavioral change. All of us, it's just the way behavior works. And so it's really critical for us also to have a good understanding of behavioral learning principles, because often we are contributing to the behavior and not aware that we are contributing to the behavior. So we're looking at tacit knowledge here. We're talking about maybe some knowledge fairs. The ACDS conference is always one way that we can all learn more and more and share and develop our services. Maybe an inclusive complex needs community of practice. I hear lots of times from organizations, oh, we're not on the complex needs list, but we serve complex needs people. And I think for all of you as surveyors, I do believe complex needs people are riddled throughout all of the services throughout the province. And I'm sure you've come across this as surveyors. Looking at a complex needs mentoring strategy, how do we mentor each other on strategies that are effective with this particular population? So again, a little bit more about Tier 2. We've got the use of restrictive practices. Environmental safeguards can reasonably address the presenting risks. Oh, you're a lovely woman. Thank you. That was very nice, thank you.
We aim to support at ACDS.
Woo! Good old Tim Hortons. The elixir of the gods, I call it. So this is, again, so restrictive practices and environmental safeguards. This is, I think, where our sector really has a lot of work to do. Because we are seeing organizations just trying to do whatever they have to do to stay safe and keep the individuals they're working with safe. So I'm sure you've come across, environmental modifications that you're going, what have you done, right? And usually it's out of some necessity to keep people safe. And what we want people to be doing, ACDS and your standards allow for all kinds of restrictive practices. There are mechanisms for every kind of restrictive practice that you can ever imagine, and I'll speak more to that at Tier 3, that fit very well within your standards. It's just, have we done all the work, our due diligence, and are we doing things properly? If I need to change a window from glass to plexiglass so that that person isn't getting hurt, how am I meeting licensing codes? How am I making sure I have proper consent for that restrictive practice? Have I involved the individual I'm working with on developing these safeguards? And do they follow CET requirements? There's lots of standards that you folks have that help us make good decisions around that. So hoping that we'll get better at that. But I think you will come across all kinds of ways that people have been trying to secure things. May require physical interventions on an occasional basis or a clinically sanctioned level. So as you know, some people, so the fella I told you about, if he were to run again, and he doesn't run anymore, which is a lovely part of the story, but if he were to run again, we would intervene. We've done that learning. We already know that's a life-threatening behavior for that individual. So our planned approaches reflect that. They tell us, this is what we're going to do in the event that this individual runs. And you folks, you know how to look at what we've done in the work and make sure that we've done that properly. But I think that's what we're after as a sector as well, just to make sure people have all the tools to make sure when we're infringing on people's rights, have we done that in a way that makes sense? And often, in my experience with complex needs people, they're the first people to tell me, Leslie, I need that knife locked away or I'm going to hurt myself with that knife, right? And so, at Scope, we have lots of funny stories about our learning. I mean, I remember one day we had someone trying to fix something, and they were up on a ladder, and they had a screwdriver, and they put it down on the counter, and they turned around, and the client had the screwdriver and was doing this. And the client went, I think you should put this away. Yeah, thank you, right? Thank you. Teach us. We'll do what you need. And there's mechanisms to do what you need, but we need your help to do that. And so I think this all fits quite nicely with what you do as surveyors. I think it just starts giving us a better frame to look at this work because it's very complex. Again, we see many similar types of living models, but then you're starting to see some odd things. Sometimes we see environments that have been locked in this level without proper consent. There's all kinds of standards. I'll talk about that at Tier 3. But there's all kinds of things people are doing with this complex group just to try to manage and stay safe, right? And I think as surveyors, that's something very important to understand because serving this group is difficult work. And you're changing and evolving every minute as people grow, heal, or become unwell. And that's one thing we know about people with mental health. Mental health is cyclic often. And so we can see people doing really, really well, and then their whole world blows apart, right? And learning mental health, when you understand that well, you can understand that has actually nothing to do with service often. Sometimes it does, don't get me wrong. Sometimes it has to do with service. But often it's really about a mental health setback, right? And so then we have to, again, looking at our services, how do you evaluate a situation where the individual is depressed and has been in bed for 2 weeks because they're on a really low cycle? So it's really important understanding the mental health piece of the individuals we're serving out there. Now this one, I just want to talk about this a little bit. We're talking about some different things again. So again, Tier 2, we're talking about complex needs standards. But we're also talking about, often there's a need for physical interventions. And so how do we make sure those are safe and proper? And we still have some work to do on this. So we say master level CPI or equivalent in your organization so that you can provide and oversee the use of safe physical interventions and adaptations to when required. So this one I think will have to be worked on because not all organizations have the ability to have a master level trainer on site, right? I'm thinking about the rural settings. I've been thinking a lot about the rural settings as we've been working on this and thinking, okay, how do we tie them into these resources? Because at this level, you need a community of clinicians as well when you're working with individuals with dual diagnosis or mental health issues. So what the master level offers you is the ability to make sure that oversee restrictive practices used in your organization, but also to make sure they're being done safe and properly, but also customizing. I don't know if you folks have come across this, but many people with disabilities require customized adaptations to hold sometimes for safety because of body limitations or whatever it may be. So that's one thing the master's level it offers that organization. So I think ACDS, that's an area to work on yet about what do we do about the rural setting folks that sometimes don't have psychiatrists, psychologists, right? How do we make sure, because they need them. They do need them, and they need that support. The clients deserve it around rights. As an individual with developmental disabilities, people have a right to receive proper treatment and support around their mental health. And so it does challenge us to think how we're going to do that moving forward. The agency has in-house mental health expertise and experience. So I will work a lot with Alberta Health Services, lots and lots. And in fact, they fund some of our supports to complex needs people because some of the folks that we serve would be living in the hospital for the rest of their life without Alberta Health Services supporting us. And so we have some tri-party agreements with Alberta Health Services. And it's very interesting to see the difference in having those alliances. So we're talking about partnerships with others. And so when in a big city like Calgary, luckily we have a community-based model. So lots of people with complex needs in other regions are actually in institutions, right? In Edmonton, the majority of folks that I would say we serve at Calgary Scope Society are in institutional environments. They're in Alberta Hospital, Pinoka. We've helped lots of people from Michener come out in the past, but a lot of complex needs individuals in other regions are not in community because of the lack of service providers really willing to take on that role of complex needs services. But the alliance with your community partners is critical. And what I wanted to say about health, it's funny because they're also, just like your community is developing, their community is developing. They're like, oh, well, we should do external case management. And as a service provider, I'm like, oh, no, we're not having external case management. We're working as an alliance, as partners. But the reality is, in the darkest of dark moments, none of those clinicians are there, right? So you can have a wonderful alliance of clinicians, but it's really those frontline staff out there 24 hours a day that are going to come across the most complex things that happen in our sector. And so we want to look at what's the in-house expertise, because when you have in-house expertise, then you manage those things more effectively. And it helps you stop firefighting, believe it or not. It lets you go to a more proactive kind of level of work around complex needs. So we're also looking at OnCall Systems, and external clinicians. So when you're talking about infringing on individuals' rights through the use of restrictive practices, this is where you want your clinicians aligned with you going, does that make sense what you're doing? Yes, that's clinically sound. It helps, it meets the treatment plan, and it actually helps you on your journey to healing, right? Because we want people to become as well as they can. And people can get quite well with the proper services. Again, our knowledge base, we're looking at identifying the pockets of excellence within our existing community organizations. I'm sure you folks have come across organizations that are just doing amazing work with people with complex needs. And I think we need to learn and share and gather and figure out from each other best practices and all those things we can do to get better at this. Looking at, as of course, the issue of cost-efficient shared community training. So is there a way that we can partner with each other and share resources? That's been on the table for a really long time, but it doesn't really materialize on the level I think it could. And so are there some things we can do with that? And opportunities and collective cross-mentoring across sector, province, and ministries. Complex needs individuals need pieces from justice, from health, and from our PDD community. They need pieces from all sectors. So how do we bring that in? And then Tier 3. So this is a group that, this is an interesting group, but I think it will share with you the scope of what's really happening in our services to people with complex needs. I think we all as a sector have acknowledged that our work's getting more and more complex. Is that a true statement to everybody? More and more really complex cases coming to our community, and how do we help with that? So this group in Tier 3, you probably won't come across them a lot, but they are out there and they are in services. So this group is less than 5% of the disabled population. So here we're talking about that small group of people that pose significant risk of harm to self and others, right? So here we're dealing with, I'll give you some examples. You know, we work with people who have post-traumatic stress disorder, a borderline personality disorder, a psychotic disorder, and they are a predatory sex offender. So they might have many, many diagnostic levels, but pose significant risk to community. And so more and more of these individuals are coming into service. We're seeing them coming up from the young group, but we're also seeing there's over 40 of these folks living in Edmonton, Alberta Hospital. And there's an interest in bringing folks to community. How do we help these folks who have been stuck in the institution for 20 years because they have some complex behavior? How do we help them to live in community? And so this group, they do meet criteria for PDD funding and the complex needs designation. They are extremely complex and they have many mental health issues. So we're talking about complex mental health, so they might have 3, 4, 5 mental health diagnostic pieces all at once. Significant risk of harming self and others, including life-threatening behavior. And so I'm just presenting here one model that we're certainly have been involved with for a long time, but there's going to be more development in this area as well, I feel, as a sector. So one model that we use as a service provider with this extremely complex is our community treatment model. And it's a secure model. It's a model that we've built over the years. We've been in service providing this model now for 14 years. And I guess I'll tell you the story of how this came to be, because it provides nice context to it. So as a young person, I started at Scope at 25 years old, and I believed that nobody ever needed to be, and we should never put our hands on anybody. We should never use restrictive practices. I thought everybody just needs love and freedom and choice. That really, as a young person, those are my belief systems. And I started to work with a lady who had post-traumatic stress disorder. She had a mood disorder, a psychotic disorder, borderline personality disorder, developmental disability. And as a result of her abuse and her trauma, she was extremely aggressive and extremely aggressive. So she went after children, pets, therapists, police, any community member. It didn't matter. And as a young person, you know, I'm thinking, well, we'll get this right. You know, we're trying to serve her in a regular house, and she's breaking the front window and chasing us around with shards of glass and cutting herself. And it just became really, really unsafe. And we did that for a long, long time with her, about 1.5 years. We got to a point where we actually had to institutionalize her until we figured out what are we going to do to keep her safe. And so she went to Michener Center for 4.5 years. And we worked with PDD. We didn't have nice, strong alliances with health back then. But we worked hard and looked at this group and figured out what we needed. And in fact, Natalie, and I have consent to tell her story, and you'll see her out there. She's a well-known woman now. But Natalie said to me, I need you to do something different. Like, I need you to restrain me. I don't want to hurt people anymore. This cops and ambulance business is no life. And so, and she challenged us, you know, like, I want you to restrain me. I need a timeout room. And I'm just like, wow, we don't believe in any of that stuff, Nat. And she said, well, what are you, chicken? That was actually her response. What are you, chicken? And so while Nat was institutionalized, her and I worked for 4.5 years. That's how long it took to get her house off the ground. But what we needed to build was a locked environment that had seclusion rooms, that had all the features that we needed to keep her safe. And so she helped design our very first unit like this. And it's been in operation now 14 years. And we currently run, I believe, 7 or 8 of these units. And we're having beautiful success for people. Because we're stopping the chaos train, right? They're not going to jail. They're not going to the hospital. They're not going anywhere. It doesn't matter what happens, your home's intact. And in fact, your home is built so that we can manage your behavioral escalations safely, and we don't have to call the cops, and we don't have to send you to the hospital, and we don't have to send you to jail. And we're going to ride out the behavioral challenge, and then we're just going to get on with life. And we are seeing people heal. We are seeing people with trauma, traumatic histories and trauma stabilize within these models because they're finally safe, right? They're finally safe and finally can do that clinical work they need to get well. And so we're seeing some pretty exciting things. We've been doing this 14 years now, and we're seeing the same results across all my models. And it's really important for people to know the philosophies of our sector still apply to this population, right? When you're safe, the world's your oyster. Choose as you need, right? Choose your passions, do whatever. These folks are out every day in the community doing what they want to do. But when they're unsafe, we can manage. And we don't have to have their lives explode. You know, I hit a staff, I go to the hospital, I hit the nurse, now I have charges, now I'm too anxious to go to court. Some of our guys lose control in the courtroom. It's just this cycle, right? And you cannot get well when you're living in that cycle. And so Tier 3, we're really looking at really unique services to people who have very, very complex needs behaviors. So our treatment model high level of environmental safeguarding. So these environments, they're probably, well, you as surveyors have surveyed our secure treatment models, and I'm sure the first time was a bit of a challenge, right? It's a locked unit, has cameras, has seclusion, has all these pieces, and yet when you meet with those individuals, like Natalie, she'll say, I built this house. Like, she's proud. It's not a bad place. People in our services like this don't say they don't like their home. They say, oh, this is safe. I like it here. This works for me. And so it's a shift, but you are coming across more of these kinds of services out there, and they're needed to keep people safe. We can't have another caregiver put in an unsafe environment with individuals who may be trying to harm them. And that's, I think, for me, one of the biggest learnings I've ever had is that I never ever anticipated that people that I would be working with would be plotting to harm, right? Harm you or harm themselves. And that's a shift for me. I never anticipated that group. And so that's the group I've become extremely passionate about, and we've had wonderful success with. But it's really unique, and it takes a lot of people to do this work properly. So environment, all kinds of types of restrictions you'll see at Tier 3. You'll see lots of egress needs to be managed, so our predatory offenders, right? We want to make sure they are not in community offending others. And so protection to community, we were horrible at that in our sector for many years. We really weren't looking after the neighbor, the person down the street, the children across. We're doing better, I think, at thinking about how do we better protect everybody. As a neighbor, you shouldn't be at risk walking out your door that your neighbor might assault you, right? And so we're just doing better, I think, as a community around community, being better community members. So you'll see sometimes egress is managed, and you have to manage a high level of risk in-house. So these environments are generally for the folks we know charges don't work. I'm sure you've come across lots of these folks in your surveys where they've had 10 charges with the police department, they're still doing the same behavior. Because often the learning is challenging for some people. Our FASD population, that cause and effect, right? So I can't remember the latest number, but the number of people with FASD in our jail system is ridiculous, right? Can't learn from their mistakes, so they continually do the same thing over and over and over again. That requires a different type of service approach. And that's what we do in here. So again, we want groups that are eligible to receive PDD funding, and Alberta Health Services, some of our really, really complex cases have involved funding from Alberta Health Services, 50-50. Again, complex needs certification at this level. Sufficient support to cover the safety concerns of the client, staff, and community. So we know this group has a compulsion to, or experiences sometimes compulsion or behaviors to harm self and others. How are you making sure your staff are safe, right? Are they alone? Do they have someone else in the environment? What are the tools that staff have in those environments? With mental health, we often use things like medications, and this is a pet peeve for me, and I'll ask ACDS to fix it one day, but PRNs can be listed as a restrictive. In some places, people believe PRNs are restrictive practice. PRNs are not a restrictive practice for people with mental illness. So if I'm hearing voices, so many of the people we serve are psychotic, and they hear voices, and I have a PRN when they're hearing voices. That's treatment, right? If I have an anxiety disorder and I am having a panic attack and I need my medication to stop the panic attack, right? That's very different. I don't believe we see medications being used for sedation in our community at all. I believe we saw that lots in institutional environments. I've never seen it in community. But I think that's an important piece when you're looking at Tier 2 and Tier 3, they have mental health issues and require treatment. It's just like the same as the non-disabled community. If we have a bipolar disorder, we take medication for that, and when we're really unwell, we would likely have PRNs. And so it's a tool, and it's a treatment tool, and so that's an important piece to recognize at this level. We want to manage in-house for this group if we can, because the minute we start calling police and charging, what's happening to lots of people with this level of complexity is they'll assault and they'll get charged, and then they go to court and they're deemed not criminally responsible, and then they have to go live in a not criminally responsible designated spot, which is an institution. So by charging people over and over again, we actually can have them be institutionalized. And I think we do see sometimes people learning from involvement with the correction systems. We've seen lots of people learn, similar to the non-disabled population. Oh, I assaulted, I got a charge, I go to probation, and I don't do that again. But there is this group with people with disabilities who do not do that learning. And so that's the group that requires a different approach, or they're going to be institutionalized. We're looking at adequate infrastructure. So do you have on-call? Do you have people who can come help in an emergency if that staff is having difficulty? Is there backup? Is there help, or is there help in-house? Generally at this level, the help is in-house all around to make sure that people are safe. Again, talking about knowledge transfer, we have a lot of work to do here. There is no legislation for the locked environments across the province, and there's lots of them out there, you guys. There's lots of them. And there's some of them on the books officially, and there's some that are just, you know, families who are trying to manage maybe a child that is running, say, unsafely at night, and they've put in a lock and alarm system and no one knows about it, you know, or there's the formal kind of environments that we try to do that are very transparent. Again, having in-house expertise important. When we talk about our community, we're looking for some legislation around these environments. And I think the legislation needs to come on a number of levels, but we need to protect the rights of people with disabilities. Nobody that doesn't need these level of services should ever be placed in these services. It should be customized support so that it makes sense and it's developed around the individual. And we want to make sure this care is clinical and ethical. And we want to make sure that we're doing a service, and, you know, not to, we never want to go back in time. So at the Calgary Scope Society, we do use seclusion, but seclusion is used as a healing tool. And so our clients self-seclude, believe it or not. And we're seeing the same results across all of our secure treatment environments. So seclusion has been presented and developed as a self-management tool. And so when people are really unsafe, we will use seclusion. But what we are seeing is people learning to control. And it can be a really beautiful tool as opposed to our archaic use of it in the past, which was very damaging and very punitive to people with disabilities. We don't want to repeat history. So we need cross-ministry housing and community resourcing strategy. We need a provincial resolution to resolve the building codes. So our building code changed last year, and to lock a door, you now need a sprinkler in your environment and non-combustible walls, right? So that means this group, until we get the building code issues solved, are supposed to live in cement institutions. And people with disabilities have rights, and we want to make sure that they are able to live in homes in the community with the features they need to feel safe. So we're doing lots and lots of work with that, moving that forward. These individuals are not safe in generic services. So we already know this, right? They shouldn't be placed in just your average services. I believe the fella involved in the fatality inquiry would have fit at a tier 3, right? that level of service and oversight and clinical involvement was required to keep him safe and others. Again, we talk about master level CPI or equivalent. Lots of agencies have different bodies. They use MANT, or there's a whole variety of them. I think what you're after is their tools in the service to make sure that your restrictives have proper oversight is really what we're after. External clinicians actively participating in treatment advisory committees, counseling, and psychiatric supports. So one thing I think we want to talk about is who are the clinicians at advisory committees, right? Like, I shouldn't have my Uncle Bob and my friend Sue doing clinical advising on this group. So advisory committees, you're really looking for expertise to come in from outside, right? And give you some clinical dialogue around what to do, looking at your interventions. Are you on track? Are you doing this in an ethical, kind manner? Is it effective, right? Does it make sense? Are people getting well? And so those are really important pieces. Again, restrictives are reviewed and approved by a clinical psychologist or a qualified person. And this is another area I think that will need some development, because there's room in CET, I believe, someone who has 2 to 5 years experience or something as a qualified person. I think sometimes with this extremely complex group, we really got to be looking at who are those people at your table, and can they clinically advise you, right? And do they provide you some protection? We've been providing these services for years, and we're quite safe in them. We have very, very few injuries of anybody. But we have a lot of oversight, right? We have clinicians from Alberta Health Services on our advisory committees. We have clinical psychologists signing off all of our restrictive practices, right? We want the transparency so that everybody knows what we're doing. We actually have footage, so these environments are cameraed because it's life-threatening behavior. And we actually show the footage to our clinicians, right? So they can review. Very transparent model. So I'm never afraid someone's going to say, oh, Leslie was doing something we don't know about. Everybody knows what we're doing, and appropriate clinicians have been involved as a safeguard for our organization. We've got lots and lots of development to do. So we need protocols. We use lots of protocols at Scope. They're not provincial. We need to develop some provincial standards around these types of environments across the province. Who has oversight? What makes sense? How many should there be? There's lots and lots of questions about the levels of service that we're being asked to provide in community. It's really important, I believe, to have demonstrated success with this population before. I don't think you want to start here at Tier 3 if you're a brand new service, because it's really complex work, right? And I think it's quite unfair for organizations to do this without all the pieces they need to be safe. You've got to have enough infrastructure in your organization, or you're just firefighting. You want to have proper after-hour response systems, so your office staff aren't running out to solve the problem, right? We want it all built in, so it's seamless. A community strategy to ensure that we're adequately trained for this work. So we need some standard development here, but that's Tier 3. So that's the 3 tiers that we've kind of come up with in the, as an initial kind of tryout for this. And so I think we're interested in people's feedback about what they think about that. I think it provides, for me, it was always a big question, would this prevent what happened in the fatality inquiry? And I believe it would, if you had to have your complex needs standards and accreditation. Then I think that would have required some different thinking to make sure that people are safe in their environments. So we have a question. Tier 3, is the legislation being considered re-ethical in clinical care and locked environments? Absolutely it is. Tier 3, we've had numerous meetings around looking for legislation. Community has surpassed government in this one. Community has gone forward and created the types of services that people need, or that services need to stay safe in community. And government has been government needs to catch up because communities just move forward out of necessity. So yes, there are conversations occurring around legislation for these environments. There's also a lot of work going on right now around the building requirements for these environments, because we don't believe everyone with with complex needs who poses risk should have to live in a concrete built structure, right? We have high numbers of staffing around, right, for egress, making sure people get out in case of a fire, all those pieces. But yes, there's much work happening at a provincial level around these environments, but also around the building code issues. So does that answer that for folks? Thank you. It's a really complex issue, and it's an expensive issue because there's more and more of these folks presenting in our sector, and there's a big question on what do we do, because institutionalizing people isn't an option. I don't believe our community would ever tolerate that again, to institutionalize people like we did in the past. I think we've evolved as a sector, and so human rights, I think people with disabilities are a lot stronger now, and I think they will speak up for being in the community. So we're really being pushed to a whole new type of service out there.
Okay. Does anybody else have any questions? Okay.
Yeah, there's like one.
Grab that.
I'll just.
You can just read
Okay.
it out, yeah?
Does ACDS consider PRNs a restrictive?
I'm going to speak to that. So when we speak to restrictive procedures, we are speaking to the fact that the staff needs to have the understanding and make a decision as to when that medication is being given. So what we are asking is that a plan be developed so that people have that decision-making ability to be able to give that PRN. It isn't that we're looking at it as being something that you shouldn't be doing, as much as they need guidance around anything that they have to make a decision to do. So that's one of the reasons why restrictives is why PRNs is put in that section. It's the fact that staff have to understand how to make a decision. So they have to, and one of the things that Leslie spoke to that I wanted to speak to a bit on is when you're developing that service, and one of the most important training that we have set is to have a really good understanding of who you are serving. So that's why when we talk about a comprehensive intake system, we want to make sure that you bring the individual on, that the organization has done everything possible to learn everything about that individual so that appropriate supports are set up, and that they're then training the staff to have a good understanding of what are the different, sometimes cluster of diagnosis that can be there, other than there's a developmental disability. What are the pieces in there? What are some of the mental health challenges or some of the physical health challenges that they might have around that? So that if people have to make decisions when to give medication, it's not that we're saying it's restrictive as much as do they have enough information to be able to make a decision on when that needs to be administered. Does that make sense? Yeah.
In addition to what Clover said, so we are also looking for the fact that you are administering PRN and you've got all the guides. Are we also seeing termination criteria? Are we also seeing strategies to eliminate the PRN that is the restrictive? For instance, if the PRN is addressing inappropriate sexual behavior, are we seeing strategies to teach the individual appropriate sexual behavior? Okay, and the termination criteria. Are we seeing periodic review of that PRN to see when it will be terminated, and what do we need to see to terminate? We don't just want to see it there and then it's there forever for the next 20 years.
Thank you. Yes.
Question though, if the situation is, say, you have someone who hears voices and they need that medication just as a diabetic would need insulin.
Yes.
That may never be,
I
that would be
agree.
the psychiatrist's.
That's exactly right. Exactly right.
So that's
Yeah.
more a part of the.
It is a part of
clinical
the
part.
treatment, however, at the same time has to be a regulation how it's given, because there is a potential for misuse of PRN. And if staff has a freedom to give that PRN whenever they feel they should give it, that can create a problem, because they can just sedate them for whatever reasons, not really give it for the right reasons.
Yeah, so for
And
the
it
sake
could
of the
be
camera, I'm going to repeat or kind of reiterate what's being said. Essentially, when there is medications that are given or PRNs that are given, there is a plan in place and that plan is reviewed. So to ensure that it is being done appropriately, decision-making around it's being done, and as one of the things that were said here, depending on the diagnosis, it's the doctors that are determining termination or changes in that, not us. We don't have that clinical background to be able to make those decisions. So you have to be careful when you're looking at those medications that we're not looking to reduce it. Think, oh, you've been on it long enough. I think that's, it's good enough. Let's just take that away. Yeah, you can have a few results there that you might not want to have. So it's very important to stay within our scope of practice. And I think that that's one area when we look at community disability services, our scope tends to be this, really, really large. And so we tend to make a lot of decisions. And especially when you're in some of those rural areas. And thank you very much for speaking to that, because I did want to speak to that a bit as well. So one of the things that ACDS has acknowledged and is starting to work towards is building capacity for some of the smaller service providers, those that are in rural areas. So we are working with government to create build some capacity around providing some resources to those areas. So we have developed some internal capacity so we can send out trainers to go in-house and provide some of the training that is needed, as well as we are also working on working with some of those teams to make sure that there are advisory teams, and so that relationships are being developed in different areas of the province to ensure that those kind of clinical needs are being met. So that's something that's in process right now, not necessarily there, but we are working on that. Yes?
I think another piece around the PRNs is that process and documentation is there to ensure that the individual is getting the medication when they need it.
Yes.
Because sometimes the opposite is true as well, that we're not treating. And I appreciate the comment about inappropriate use of medications as well. Our sector, we've witnessed people being over-medicated for behavioral management. I have to say, in my 30 years working in mental health, have never come across that in the community, you guys. Psychiatrists will not just provide meds to sedate people. They will provide only to treat. And so I think sometimes that old history comes back a bit to haunt us, but honest to goodness, I've not come across that in the community in 30 years. So maybe it is. I don't want to say it never happens out there, but I think we're seeing different, more clinical care for people with developmental disabilities and mental illness.
Definitely. Yes.
Leslie, I think it's kind of it's still a little bit prevalent out there. We see a lot of the folks that we support, especially high anxiety, high aggression. Ativan is a sure prescribed medication.
Yeah.
So basically the way we view it is if there's a formal diagnosis by a qualified professional, there's criteria for administration, there's a reporting process behind there, and then termination criteria that fits the bill for a PRN restrictive.
Exactly, and as you know, Ativan is a treatment for anxiety, but Ativan is one of those medications that provides a pleasant effect and tends to be misused sometimes, right? So you're exactly right. There are these certain meds we know about. There's not very many of them, but Ativan is one of them. Yeah, really good point, yeah.
Yeah. Anyone else?
It's unclear going into an agency. Is it the agency that's going to distinguish what tier an individual falls in, or PDD, or?
Should be the organization and their clinical assessment. And I think this is where we have to be careful, because PDD is a funder, right? And so should they be expected to make clinical decisions about where someone should be? And so there has to be that work together around, and there is much work to do moving forward around who does end up. For me, the tier 3 guys are usually pretty clear, because at the minister's level, they're causing havoc in the system, and it's pretty clear they're tier 3 folks. But you're exactly right about that. Yeah, well, there's lots of work to do on that.
And it's very much the agency that knows the individual, so the agency is really going to be the one that's going to, take all of those steps to really make some decisions on what's needed for that individual and what kind of training is needed in that.
I think our sector's working hard, like there's cases coming right now where they're pulling big think tanks together before these folks come to community about what they need. So I do think we're being more careful about how that happens. Go ahead.
I think when surveying, we see there's so much subjectivity to it now for the service providers. And they say, oh, all of these people are considered having special needs. And my team will say, well, behind doors, they'll say, that's not how they think most agencies would look at it. Those people wouldn't be considered to be tier 2 or tier 3.
Exactly. No, you're
So
right.
how do we, how are we going to deal with that?
So in the definition, there is very specific criteria. I would refer organizations back to that specific, and when we are doing that as well. So when they're saying that, oh yeah, we want to do complex needs kind of thing, we're referring back to the very specific criteria to actually say that, yeah, you do meet this need for complex needs. Because PDD and Alberta Health Services did develop very specific criteria around that. So there is, lots of organizations that say that they serve on specific levels, but there is written criteria there already. Yes.
So one thing is that there, as Leslie brought up, there's not really specific criteria for what might be medical complex needs. So I'm thinking specialized training, safe to risk to harm for self if they're not able to take care of themselves. What other suggestions do you have for agencies if they're thinking about how do people with difficult?
So that's our next presentation, is on the medical ones.
Okay, thank you.
Yeah. And I think ethics, I did think about that a little bit, and I thought, well, I bet you there's a need for an ethical review, because then you're dealing with life and right, those kinds of decisions. There might be medication you can take, but it's going to decrease the quality of your life, or a treatment, or you can choose not to have the treatment. So for me, there'd be a lot of need for ethics reviews with complex medical. But that's definitely not my area of expertise, but Elaine is going to speak to that, and it's great.
Thank you, Rita.
Can I just have one question around those that are not being served? There's some small communities that we go to where, based on capacity, they're within the organization getting served, and then we happen to run into people in the community that are receiving no services because there's no capacity. So what obligations are there for the community at large, our community at large, to ensure that they're not falling through the cracks and they're getting served?
Mm-hmm.
And we've heard that as part of exits also, saying we know there's people out there that need our service even more than the people we're serving, but we don't have the capacity. So they're the ones that are being served generally by the community who has coffee with them, and they're the ones that put themselves at risk for those individuals.
You're exactly right about that. And there's a lot of people, and there's even a large street population in Calgary of people with developmental disabilities absolutely in harm's way. And you're really right. And the only thing I have found that works is to get them classified as PDD eligible, because then I can push once there's eligibility. Because for me, the really complex guys, for many years, it was a bit of a fight to to make it clear, these guys do meet mandate. Yes, we don't have the right services for them in the community, but you are mandated to serve this group. So once you get the eligibility, that's the only tool I've found to push that.
Well, we're seeing like some organizations, such as the one to my left, that are working with the police workforce and are identifying those factors. And I think there has to be those opportunities as well, so that there's a flag, and then we won't see as many people not served that need to be served.
I think that's a really interesting piece, and I don't know where it fits, but that is a piece, because there's a lot of people falling through the cracks. And how do we catch that?
There is another initiative, a specific initiative for those, for funding for those who have unmet support needs that sometimes don't exactly meet the mandate as well. I've had them call and beg me for services, but they don't meet the mandate. But they can go through family managed, and there is other funding for that. Unfortunately, the need is far greater than those who are accessing support. And one of the issues is that people don't know that support is available, especially if they're not connected to some of those resources. So all we can say is that when they go to places like drop-in centers and things like that, they have to have that information to be able to know where to access that support. It is available on a very small scale. There are huge cracks and a lot of people falling through it. We are becoming more and more aware of that and are advocating for that, so yeah.
AACL is a great idea as well when you're advocating, because they can help us. Yeah. Good. Thank you, everybody.
So thank you very much, Leslie.
Thank you.
We have a little gift for you.
Oh, it's lovely. Thank you very much. Thank you. Thank you very much.
So yes, on behalf of ACDS, we really appreciate you coming to share your stories and to speak with us, and all the work you did to develop all of this stuff with us.
Oh, happy to
we really
do so.
appreciate it. So
Thank you. Thank you very much, and thank you, everybody.